My name is Reshma Mahtani. I'm a breast medical oncologist, assistant professor of medicine at Sylvester Cancer Center, University of Miami. So this morning I reviewed some of the exciting abstracts that were presented in the breast cancer arena at ASCO 2017. In the metastatic setting, I reviewed studies that were evaluating the use of CDK4/6 inhibitors. Basically, the two abstracts that I reviewed were the Monarch 2 trial and the Paloma 1 overall survival analysis. So an evaluation of both of these abstracts again confirms that CDK4/6 inhibitors are a very important type of therapy that has now been shown to help identify pathways that mediate endocrine resistance. In the Monarch 2 trial, we reviewed results of the CDK4/6 inhibitor abemaciclib in combination with fulvestrant in a patient population that was ER positive, HER2 negative in the metastatic setting, and patients that received abemaciclib in combination with fulvestrant had about a 7-month improvement in PFS compared to fulvestrant alone. In the Paloma 1 trial, this was the trial that had the longest follow-up for a CDK4/6 inhibitor. It was a phase 2 study looking at palbociclib letrozole versus letrozole alone. Unfortunately, we were not able to identify an overall survival difference with the use of the CDK4/6 inhibitor palbociclib, but certainly it is important to note that this was a phase 2 study that was not powered to look at this as an endpoint, so we're eagerly awaiting the results of the Paloma 2 study and the Mona Lisa 2 trial, which will hopefully give us more information on that endpoint. Moving on, I also discussed immunotherapy in breast cancer, and I reviewed 2 studies, the KEYNOTE-86 trial and the I-SPY 2 trial, which looked at the use of the checkpoint inhibitor pembrolizumab in the metastatic setting in the KEYNOTE trial and in the neoadjuvant setting in the I-SPY trial. Certainly here, we're again a bit disappointed to see that immunotherapy has not made as much of a splash in breast cancer as we've seen in some of the other tumor types, perhaps because of the differences in mutational burden with breast cancer as compared to other tumors. But we did see that there is activity with pembrolizumab in patients that are PD-L1 positive and also PD-L1 negative, although responses are low. In the neoadjuvant setting, we were able to identify that this drug was one of the only drugs that's graduated on the I-SPY 2 platform based on the I-SPY 2 pembrolizumab data that showed an improvement in path-CR. And then finally, moving on to the adjuvant setting, I discussed the very important affinity trial, which looked at the use of pertuzumab in the adjuvant setting. I think one point that gets missed in the analysis of this trial is that it was a positive study. The magnitude of benefit was quite small, and we also have the cost consideration and toxicity considerations in making this decision. It was a positive study, and in patients that have multiple positive nodes or are high-risk ER-negative patients, I would certainly consider the use of adjuvant pertuzumab in that setting.